All right, well. All right, welcome to our next session. This is going to be novel therapies for HPB malignancy. My name is Perry Shen. I'm at Wake Forest, Atrium Health Wake Forest in Winston-Salem, North Carolina. I'll be one of your moderators.
My name is Cecilia Yarem, Guillermo Almenara Hospital, Lima, Peru.
We got a pretty full schedule. They gave us an hour for 5 talks, which are going to be about 10 to 12 minutes each. And I guess we should leave some time for questions as well. So be prepared to stay over a little bit if you have questions. I think there's a break after this, so we can get the benefit of the full discussion here. We'll go ahead and start with our first speaker. We got a great lineup of talks here and some very distinguished presenters. Our first speaker is Dr. A.J. Maker, and he is the Morris Galante Distinguished Professor of Surgery and Chief of Surgical Oncology at UCSF. He's going to talk to us about novel immunotherapeutics for colorectal cancer liver metastases.
Well, it's an absolute pleasure to be here, and I'm very thankful to the HPBA and the program for the opportunity to be with such illustrious colleagues today. This is a fun thing to think about, and this is our present and our future of how we're going to be managing these patients. Now, 1 in 100,000 cells, 1 in 100,000 cells will make their way from the colon to the liver and actually make it there alive. What does that mean if we put that in context? Well, if you take everyone that goes to a 49ers game and add 2 weekends together, that one person that went out to get a hot dog, that's 1 in 100,000. Not very many. And yet, this is the most common site of metastasis from any cancer in the GI tract. And up to 50% of patients with colon cancer will end up having a liver metastasis during the course of their disease. So obviously, there's something unique in the liver that's making this happen. Well, what about immunotherapy? Immunotherapy is being used for everything. Is there any role for it? And that's a little bit of what we're going to address today. Is there any role for it in colorectal liver mets? Well, we just looked at a very large grab bag study of all immunotherapies in about 10,000 patients combined with chemotherapy in the adjuvant setting, and just said, is there a signal here? If you combine immunotherapy, are there patients that will have improved overall survival? And we think that there is a hint that there's a signal that if we choose the correct patients and choose the right therapies, maybe there is a role for immunotherapy. So I hope by the end of this 10 minutes, we have an idea of what some of those agents and who those patients are. Because the liver is different. If you use chemotherapy based on the recent JCOG trial in the adjuvant setting after resection of colorectal liver mets, we know now that there may actually even be worse overall survival, right? And even our colleagues in medical oncology are recognizing this. So there's something different that's happening. And it's different because the liver is a cold niche. What that means is that it is currently unresponsive to current checkpoint blockade immunotherapy. And I show here the original anti-PD-1 trial, but there were no responders. And this was the same in the original anti-CTLA-4 trials. It is cold, okay? Now, what about current immunotherapies that are being used in advanced colon cancer, like anti-EGFR antibodies? It seems like if you add those in with chemotherapy, overall survival may actually be better than the traditional 2 years with multi-agent chemo. However, it turns out, based on the new EPIC study, that you may actually have worse overall survival if you add anti-EGFR specifically in the setting of colorectal liver mets. So again, there's something different that's happening when cancers get to the liver, because the liver is different. If you take traditionally hot tumors that respond to traditional checkpoint blockade immunotherapy, and you now take those same patients, but they have liver metastasis, they are no longer responsive to the checkpoint blockade immunotherapy survival and response rates just by having liver mets, everything else staying the same. And if you measure the number of anti-tumor immune cells that are circulating in those patients, there's less. Now, how can that be happening? Beautiful study just came out last year. Turns out that there's macrophages in the liver that recognize these anti-tumor immune cells and through a fast ligand interaction, cause them to apoptose. So you are siphoning off your anti-tumor immune cells when you have a liver metastasis. This is a very unique situation. And what it leaves behind is what we term an immune desert, where all these anti-tumor immune cells are being siphoned off and you're left with only those suppressive immune cells, creating a pro-metastatic niche. Okay, but what if that environment already is quote unquote hot, like in mismatched repair colon cancer that is metastatic? Well, here there is a very nice signal. 40% of patients that have microsatellite unstable disease will actually respond to anti-PD-1 therapies. Okay, and this is an exciting subgroup of patients. And when you look at it a little closer, this nice study out of Canada tells us it's not just MSI status, it's really a proxy for what are the neoantigens, how many unique antigens are being presented on these tumors for which checkpoint blockade immunotherapy can work. And it turns out the cutoff is about 28. And if you have more than 28 mutations, you'll actually probably be responsive to classic checkpoint blockade immunotherapy. Now, interestingly, in the Keynote 158 trial, upon which the FDA approval of pembrolizumab was gained for tumor mutation burdens greater than 10, there actually were no colorectal cancer patients in that entire study. And yet, based on that FDA approval, this is what we can use to treat our patients with metastatic colorectal cancer that have high tumor mutation burden. Okay, but the reality, of course, remains that the vast majority of colorectal liver mets are actually going to be low tumor mutation burden, on the average of only 3 to 4 unique peptides per tumor. I mean, this is a very small amount, and 97% of colorectal liver mets are going to be microsatellite stable. So based on all the clinical trials that have looked at checkpoint blockade in these patients, response rates are close to nil. So I think it's pretty clear from what I showed you that the microsatellite stable mets are cold. And to use checkpoint blockade immunotherapy as we know it, without targeting the molecular pathway that excludes tumor-infiltrating lymphocytes just will not work. And so what we have to consider is first recruiting these tumor-infiltrating lymphocytes into the microenvironment, turn that niche, that environment hot, and then perhaps we can combine it with other known immunotherapies. Now, why do we think this might work? If we look at a very basic study, we looked at about 150 resected colorectal liver metastases and just stained them for different T cells. And if you have increased infiltration of the traditional T cells into a colorectal liver met, your overall and recurrence-free survival is improved. So based on this, what if you combine, say, cytotoxic chemotherapy to cause immunogenic cell death, release neoantigens, and try and get more lymphocytes into the tumor microenvironment, and then combine that with checkpoint blockade immunotherapy? Well, the highly touted Rego-Nivo trial was really meant to do this. And, excuse me, the Tezo tribe, I can't even see that far. The Tezo tribe trial. And it turns out that in these patients, when you had microsatellite stable disease, they did not have improved response rates. And so chemotherapy plus immune checkpoint blockade for microsatellite stable patients really has limited value. And that was proved again in the Bocce and in the Checkmate trials that followed. Okay, how else can we recruit TIL? You can use tyrosine kinase inhibitors or anti-VEGFR. Now, this first trial, this was done in the Far East, and it had a very high response rate in microsatellite stable tumors in about 25 patients. This was highly touted. Everyone was very excited about this. When it was repeated in the United States with about 50 patients in a phase 1 trial, the response rate actually was less than 10%. And all the combinations of tyrosine kinase inhibitors plus immune checkpoint blockade to date have had limited value. And in fact, if there's liver metastasis in particular, response rates are close to 0. All right, well, if we can't find other ways to get lymphocytes in the tumor microenvironment, why don't we just force them in there by using adoptive cell transfer or CAR T? The original trial that did this using anti-CEA CAR T, and this was a beautiful trial. It was done at the NCI. And the first 3 patients had remarkable decreases in their serum CEA levels. They also, however, had rip-roaring colitis in their non-cancerous liver. So there was dose-limiting toxicity. And now we're on second generation anti-CEA CAR T. So there's still some excitement in this without colitis in the second generation. However, response rates are now down around 20% with that current strategy. But as I'm showing you in this table, this is how many clinical trials are currently ongoing with CAR T cells for colorectal liver metastasis and advanced colon cancer using other various tumor-specific antigens. There's a really exciting trial that just came out of China with 8 patients. It was presented at ASCO a few months ago. 50% response rate using a CAR T against GCC. We just opened up this trial at UCSF and put the very first patient on that. And I'm very excited to see how these CAR T trials with tumor-specific antigens are going to fare for our patients with colorectal liver metastasis. Now, another way of getting T cells in the tumor microenvironment would be with a bispecific antibody. One arm of that antibody pulls in a T cell, anti-CD3, anti-CD4. The other arm is to the tumor-associating antigen. It could be EGFR or GCC or CA or whatever you're trying to target as a neoantigen. Now, we did this using an anti-EGFR and an anti-CD3 and a bispecific antibody, and we found that we could actually pull T cells, here I'm showing CD3 and CD8, into the tumor microenvironment in a very robust way. And there's some advantages to bispecific antibodies. They're off the shelf, and they don't have to be custom made like a CAR T. In this case, this current antibody that we used is now in clinical trials for pancreas cancer. But there are other exciting bispecific antibodies. This was presented at ASCO GI just a few weeks ago, looking at anti-EGFR with anti-CD8, which is a co-stimulatory T cell molecule on the other side. And the other phase 1 that was presented a few years ago at ASCO GI was looking at anti-CEA and anti-CD3, and in a small number of patients did have a 50% response rate. These are still in trial. Now, what if we could find other ways to get T cells into the tumor microenvironment? So we looked at about 100 resected colorectal liver metastasis and found that if you had increase in this tumor necrosis factor superfamily cytokine, that you actually could have improved response rates, overall survival, disease-free survival. And if you then took that immunocytokine and overexpressed it in a preclinical model of colorectal liver metastasis, you could draw T cells into the tumor microenvironment. So these are just strategies to try and get these T cells there and start to take these cold tumors and make them warmer, so towards getting them hot, okay? And so in this model, if you do no treatment, livers are completely replaced by tumor. You use checkpoint blockade or immunostimulatory cytokine alone, you get partial responses. And if you combine them, you get total responses. And that's what's so exciting, right? If you can choose the right combinations of pulling in the T cells and then giving them the checkpoint blockade, you can potentially eradicate this. And translating this into our patients is where we need to go, because this is how we think it's working. We think this is working because when you have just untreated colorectal liver mets alone, they're full of these suppressive cytokines, this immune desert, this MDSC, T regulatory cells, macrophages. And if you get rid of these populations, which is what happens with monotherapy, you can actually start to turn that environment warmer. And then if you combine the two together, you can get rid of the rest of the immunosuppressive cells. And that's how we figured out, at least this combination is working. Turn cold, hot, okay? Now, wouldn't it be cool if we could deliver some of these treatments directly into the tumor vasculature itself? And this is a little setup for Dr. Jarnigan, who's following me next. We have a robust pump program at UCSF, and we use FUDR. But what if we could use other things in there, like some of these cytokines? And that's currently what we're working on, is finding ways to get these new immunotherapies directly into the liver, because we have the highway to do it. So we've created an oncovirus that can deliver its cargo, its immunostimulatory cytokines, directly into colorectal liver mets. And now we actually have nanoparticles that can deliver mRNA for our particles directly into these liver mets. And this is what we're really excited for in the future. So in conclusion, the liver is a pro-metastatic niche. It's an immune desert where anti-tumor T cells are consumed. Traditional chemotherapy is not durable. And it actually, I'll say it here, it will have a very limited role moving forward. And we think it might even be harmful after removing liver metastasis. Immune checkpoint blockade in its current form is not active for microsatellite stable mets. and current and future therapies have to turn liver mets hot to work. So they should target microsatellite unstable tumors at the current time, tumor mutation burden of greater than 10 to 28 mutations in neoantigens, and in the near future, utilize CAR-T, bispecific antibodies, and these novel combinations. I'm very thankful to my group at UCSF, which is an amazing group to work with, our sources of funding, and all the members of our lab that did much of the work that I showed you today. I thank you very much for your kind attention.
Any questions, quick ones? Okay, we'll just move on for a second time.
Yeah. Sí. The second speaker is the Professor William Yarnagan, is the Memorial and Sloan Kettering Center Cancer. The topic is HPB, up-to-date evidence and applications.
Great, thank you. Thank you for the introduction. Thanks to the organizers for the invitation to talk. I thought it was a little hysterical that they put me in this panel with this topic, because arterial therapy for tumors in general is far from a novel concept. All right, this is a slide from a review paper published, written by one of our trainees recently, outlining the history of arterial therapy, and the first such administration goes back to 1950, so nearly 80 years ago. So this is something that people have been thinking about for a long time. And HAI chemotherapy, in the way we think about it with a continuous infusion pump of FUDR, is also not very new. This is one of Dr. Kemeny's very first papers on the clinical use of this. And you can see it was published in 1984, where I would say a good majority of the audience may not have been born yet. So this is a study of 41 patients using continuous infusion of FUDR. 61% of these patients previously treated, and 50% tumor regression was seen in 38% of patients. So this was the first sort of signal, if you will, that FUDR, continuous infusion chemotherapy, would be effective or could be effective. So if the treatment's not novel, then what is novel about HAI chemotherapy? I mean, certainly HAI chemotherapy is targeted therapy in the same way that I think an atomic bomb is targeted therapy. All right, it's not a sophisticated immunotherapeutic designed to attack tumors at the molecular level. It's designed to just wipe them out completely. So it's kind of like a big bully in the room, as opposed to the more elegant other therapies that are coming along. But what is novel about HAI chemotherapy is that people are using it more. There is mounting clinical evidence showing efficacy in a number of different tumor types, and I'll discuss the evidence for two of those. There's increasing recognition of the limitations of systemic therapies, which Dr. Maker pointed out so nicely in terms of chemotherapy for metastatic colon to the liver. The great excitement over that these new drugs were going to really have a huge impact has just not been realized. And as a result, there are expanding indications for the use of HAI chemotherapy, including colorectal liver metastasis, not just in the adjuvant setting, but also palliative and conversion therapy, and also in primary liver cancer, primarily intrahepatic cholangiocarcinoma. This is a slide from Mike Lidsky and Mike D'Angelica, just showing the number of medical centers around the country and also into Europe who have established pump chemotherapy programs, and this number is growing. And so this is, it's taken a long time for people to realize the potential benefits of this approach, but it's starting to come, and this is evidence of that. So the liver has been a very favored organ for arterial therapy for many reasons. Firstly, favorable anatomy with respect to the blood supply, not only the arterial anatomy, which allows a simple surgical procedure to put the catheter in the GDA and allow perfusion of the entire liver, but also the dual blood supply with the portal vein, which allows treatment intraarterially of the tumor where they derive their blood supply with sparing of the normal parenchyma. All right. There's also a detoxification element in the liver. FUDR is given in doses that are not achievable systemically within the liver. And the reason patients don't get significant toxicity is the drug is broken down completely before it exits into the hepatic veins. And there's also been technical developments in the development of the continuous infusion pump, which is now made by Intera. And the liver, of course, is a common site of malignant disease, metastatic disease, of course, intrahepatic cholangiocarcinoma. And both of these tumor types are very sensitive to fluoropyrimidines. Patients with liver confined or liver dominant disease are very common. Treatment options for both of these tumor types after failure of first-line therapy have really limited efficacy to date. And certainly as you get into beyond second line and third line therapies, the results are very poor. So that's where HIIC, I think, has a real potential benefit as well. So let's go over some of the evidence. First, in patients with resectable metastatic colorectal cancer, this is Dr. Kemeny seminal paper in the New England Journal of Medicine, now almost a quarter century ago. In this study, she showed that patients with resected liver metastasis of colorectal cancer treated with either 5-FU alone or 5-FU plus HAI chemotherapy had improved, the pump patients plus systemic had improved survival. And one of my graphs is missing. I don't know why that is, but in any event, the study that was published was designed, powered to compare 2-year survival or compare survival at 2 years. And it met its objective. The median overall survival, 72 versus 59 months in that study. And the updated results are shown in the graphs above, where there is ongoing benefit seen well beyond the 2 years and actually into 10 years. Now, since then, there has really not been a randomized controlled trial looking at pump as an adjuvant after resection of met colorectal, but there has been an overwhelming amount of circumstantial evidence. And as we all know, people get convicted and put on death row for circumstantial evidence. So it's not unreasonable to think that we can use this circumstantial evidence to support pump chemotherapy in the adjuvant setting. This is the first such study published from our group, Mike House, first author, looking at nearly 600 first-time liver resections. 125 had HAI pump placement and also had systemic sulfoxafulfurialone. And the comparison group was patients who had resection just with systemic therapy. And this is the breakdown of the groups here. You can see by good selection of the patients who were able to weed out any outliers, and the groups were well matched. And here's the results. And you can see the curves very, very clearly that with respect to disease-specific survival, hepatic progression-free survival, and overall survival, patients who had a pump did far better than patients who had systemic alone. And then in a follow-up paper, looking at over nearly 2,400 patients, this one published by Dr. Bas Groot-Koorkamp when he was a fellow with us. Propensity score analysis was used to match the patients according to 7 known prognostic factors. And the use of HAI treatment increased overall survival by 2 years and was an independent survival variable. So what about in patients who have unresectable disease? There is, in fact, a randomized study that's not well known, done by Dr. Kemeny and others, looking at this question of 135 patients that were recruited over a 4-year period with advanced unresectable disease, randomized to HAI FUDR without any systemic therapy, by the way, or to systemic 5-FU alone. And of course, the argument for is that the patients were not getting the best systemic therapy, and of course, that's true. On the other hand, the pump patients were getting no systemic whatsoever. But regardless, 70% of these patients had at least 30% or more liver involvement, and only 3% had failed prior treatment. So a lot of these patients had prior therapy and responded, and then fell off and started to progress. And you can see that the patients who got pump chemotherapy had a prolonged survival compared to those who were treated with systemic 5-FU alone. I think a more compelling argument for the use of pump chemotherapy in patients with unresected or unresectable disease is this retrospective study done from our center. Andreas Sursik as the first author. And this is really amazing. It's 110 patients treated with at least 3 different systemic regimens of chemotherapy. 57 of these patients had liver-only disease and 53 had also extrahepatic disease. And in this group of very heavily pretreated patients, 35% response rate, which is quite remarkable. Median overall survival was 20 months in patients who had liver-only disease and much less for patients with extrahepatic disease. So I think it really illustrates the potential power of this treatment. And this is a study published a few years ago with Dr. D'Angelica as the lead, a randomized phase 2 study in patients with unresectable liver-only disease, randomized HAI, FUDR, and FOLFOXIRI with or without Avastin. The Avastin had to be held because eventually we realized it was causing too much toxicity. But these are patients with fairly advanced disease, very good overall response rate, and over nearly half of them converted to resectability. Now, updated data from this trial, 64 patients, median of 12 tumors, 2/3 previously treated, 33 patients converted to resectable, and at a median follow-up of over 5 years, the 5-year survival was 43%. So again, it's a very powerful potential way to get patients converted to potentially resectable disease. So for the last minute and a half or so, I will talk about the evidence for HAI chemotherapy in intrahepatic cholangiocarcinoma. This slide just shows a group of papers over the past 25 years, showing that the age-adjusted incidence and mortality from intrahepatic cholangiocarcinoma is increasing worldwide. And the graph at the far left, which you can barely see, looks at incidence of intrahepatic cholangiocarcinoma in 24 countries around the world. And all of the curves, and that's over the last 25 years, all of the curves are going upwards. A lot of reasons for that we can talk about at some other time, but it's a disease that's getting more and more common. And as we all know, biliary cancers can arise anywhere in the biliary tree, from intrahepatic radicals down to the extrahepatic ducts and gallbladder. And many studies looking at patients with biliary cancers, particularly getting chemotherapy, are kind of all lumped together, which is unfortunate but necessary because of the small numbers. But it's important to recognize that these are different diseases with different driver mutations and different clinical behaviors. And beyond that, intrahepatic cholangiocarcinoma, above and beyond the other biliary tumors, is notable for very marked tumor heterogeneity. And there's a number of reasons for that. And excuse me, sorry, I went too fast there. First and foremost, there are many different potential cells of origin of intrahepatic cholangiocarcinoma, ranging from hepatic stem cells or transformed hepatocytes or biliary epithelium within the canals of Herring. And this is unlike the extrahepatic tumors, which generally arise only from the biliary epithelial cells themselves. So this gives rise to a situation where patients with advanced disease and multiple tumors, there will be, even within the same tumor, different populations of subclonal driver mutations that may not respond to the chemotherapy that other populations respond to. So it has made intrahepatic cholangiocarcinoma a target of intense study because of the biology, which is very interesting. But it also has made it very frustrating because trying to define the genomic features that characterize this tumor has been very difficult. In this study, the ABC-02 trial established GEM-CIS as the standard of care for treating patients with advanced biliary cancers. 410 patients, again, treated, kind of all lumped together, all biliary cancers. But it was clear that the addition of cisplatin to gemcitabine was a significant advance of many months in terms of survival. And of course, more recently, we've seen the durvalumab in the TOPAZ-1 trial, GEM-CIS plus durva versus GEM-CIS alone, once again, including all of the biliary cancers, showing an improvement, although pretty modest, really, when you look at it, a 40-day median improvement in overall survival. And the benefit really seemed to be greatest in patients with extrahepatic tumors and Asian patients. So, but nevertheless, that is now standard of care in the United States. Pump chemotherapy is something that we started doing because we really had limited treatment options at the time. And this is the set of scans on the top right showed the first patient we ever treated, and you can see the marked response that he had. And then we looked at our results after about 25 patients, and we saw a significant improvement in patients compared to systemic alone, even in patients with liver-limited disease. So this led us to embark on 2 clinical trials, the results of which are summarized here, and I'll go quickly now because Perry's looking at his watch. That when we looked at the patients overall, we noted a median overall survival of nearly 30 months, which is really not something we see with systemic therapy alone. And when we compared the long-term survivors, of which we had 10, or about 40% of the group, compared to the patients that died quicker, the only thing that stood out was the fact that progression-free survival in the liver was greatest in the patients who lived the longest, suggesting if you control the liver, that the patient does better. This led us to a phase 2 study that we did in conjunction with Washington University in St. Louis, 42 patients that were randomized, that were treated with pump plus systemic therapy. And the table shows the features of these patients. You can see very advanced disease on all of them, and impact analysis, genomic analysis for all patients. Don't have time to go through all the data, but all but 1 patient had some degree of tumor regression. Disease control rate was 97%, and three patients were resected. 1 had a complete response. The other thing that we noted, which was interesting, was that while lymph node metastases were common in these patients, it had 0 impact on overall survival, which is unlike in patients who are undergoing resection. And then speaking of lymph node metastasis, this also is an interesting study in terms of pump therapy. This looked at patients treated with either resection, pump chemotherapy, or systemic therapy, all with liver-confined disease. Node-negative patients on the left, node-positive patients on the right. And you can see that in patients without lymph node metastasis, the resected patients do the best, of course. Pump patients, not so great, but better than systemic alone. In the face of lymph node metastasis, however, resection and pump chemotherapy are nearly identical in terms of long-term outcome, and both of which are better than systemic alone. So, and we actually see the same thing in a paper published by Bas Groot and his group in patients with multifocal intrahepatic disease as well. In those patients, you lose the benefit of resection by nature of that advanced disease. Just one slide to show that there's now an ongoing randomized trial at 5 centers in the US and in Europe, looking at this question of whether pump chemotherapy does improve survival over systemic alone. So we'd invite you to send your patients if you wish. And with that, I will close and then remind everyone about the 2024 World Congress in Cape Town. We hope to see you there. Thank you very much.
Some question of audience.
These are all great topics. We could spend an hour on each one, but we'll move on to our next talk with Dr. Jonathan Hernandez. Dr. Hernandez is Chief of Surgical Oncology at the NIH, and he'll be speaking to us about immunotherapy for cholangiocarcinoma.
Thank you for the opportunity of the floor. Your computer crashed, you said? Everybody will just close your eyes and picture wonderful slides. No, I'm just kidding. Sure.
It's your slides.
While we're waiting, I guess I had a question for Dr. Jarnigan. That clinical trial, I couldn't quite read all the details. Is that HI therapy and then the systemic regimen is GemOx, or is it what is it currently?
It's systemic therapy with GemCis with or without pump.
Okay.
In patients who have unresectable liver disease with or without nodal metastases. Now the interesting issue now comes up is, now that durvalumab is approved, that's not part of the systemic regimen. So the question comes up as to whether we need to add that as part of the treatment for the patients randomized to in the systemic arm or not. We can't really use it with the pump because it's not been tested and we have no data on that. On the other hand, the group in Netherlands that will be part of this study, they don't really care about that because durvalumab's not approved there for this purpose. So, so it kind of confounds things a little bit. And there are patients. This is a very well-educated group of patients by and large, and when they hear about the trial, they hear they're not getting immunotherapy, and they're not so hot to enter. So even though if you explain to them the incremental benefit of durva is not that great, even still.
Yeah. Any other questions? I get one other question I did have.
Oh,
Is just
okay.
in a laptop, but
In the interest of time, I know.
okay, we got it.
Ryan's chomping at the bit a little bit. I'll try and go a little quicker. So you just heard about durvalumab. We are in a different place with cholangio than we are for metastatic colorectal cancer. We're all familiar with agents that come along, will look really good in the phase 2, but fail in the phase 3. This is a randomized phase 3. You heard Dr. Jarningan talk about the minimal benefit. We'll go through that a little bit, but this trial, Topaz 1, gave us durvalumab. Just as a brief background. So about checkpoint inhibition. So CTLA-4 is the first checkpoint I'll talk about. So this, we think, happens in a lymph node. So when a T cell recognizes a neoantigen or an antigen from the tumor through the T cell receptor, requires co-stimulation. If CTLA-4 is present and binds with B7 and sequesters that, you get no stimulation. But if you don't, you have that T cell is primed. This is an oversimplification, but just for the purpose of this talk, I think it makes sense. That T cell is primed. It can go recognize a tumor cell. And as long as that tumor cell doesn't express the PD-L1 don't eat me antigen, this T cell will kill this tumor cell. And so the concept would be, of course, to block the PD-L1 such that that primed tumor cell can then prime T cell can then kill that tumor cell. And that's what durvalumab is. It is an anti-PD-L1 antibody. The truth is it's far more complicated. PD-L1 for human cholangiocarcinoma is mostly expressed in macrophages, but this makes sense for this sort of talk. Okay, so this is the Topaz 1 study. Who was eligible? It was people with cholangiocarcinoma, intrahepatic, extrahepatic, and gallbladder. Patients got Gemcis with durvalumab, and they then continued durvalumab, or they got Gemcis and they got placebo. When you look at the survival curves, the p-value is significant. There is a difference, but it is, as you heard earlier, modest. And if you look at the hazard ratio in the first 6 months, it's no benefit. You could say this is primary resistance. Now, you could argue with me about my box should be farther over. I wouldn't argue with you about that. But if you look at the sort of end of this, there is a tail on the durvalumab group. And so there is a group of patients that are benefiting here. It's not a huge benefit, but there are people who are benefiting. And so you ask yourself the question, how would we make this a better therapy? How can we move forward? Well, it would sort of be inherent, it makes some inherent sense that we should pick patients with high PD-L1 expression. And so the authors, as a pre-specified endpoint, looked at this score, and this was a score based on tumor cell expression of PD-L1, immune cell expression of PD-L1, and they sort of came up with a scoring algorithm. And you would say, okay, let's we should treat people what should we look at? We should look at 1%. Okay, so does this work if you use a 1% cutoff? Not quite, it doesn't quite meet significance. What about 5? Well, 5 looks okay. If you pick a score of 5, that looks okay. Maybe we should pick people and only treat the people who have a score of 5. But if you move that cut point even higher, it doesn't work anymore. What I will submit to you is that we don't know who to treat. The situation we're in is we have an approved agent now, durvalumab. It's held up in a randomized phase 3 trial. It is immunotherapy. People like immunotherapy. We don't know who to give it to. Obviously, you get the feeling like we're getting ready to sort of go on a roller coaster. And there's a lot of, because we have a new class of agents approved, there's going to be a lot of things happening. So I put this slide together just to show you the ongoing immuno-oncology agent trials in cholangiocarcinoma. The blue boxes indicate trials that include durvalumab. The yellow boxes, there are far more of them, indicate trials that don't include durvalumab as a component. But what you can see is you're going to see a lot. And so the goal is going to be, how do we make durvalumab work better or for more patients? And if HCC probably leads the way in liver cancer and immuno-oncology, you're going to see combinations with TKIs. There's lots of stuff we're going to see. These trials are not being run by us. This is not our task. These are our medical oncology colleagues' task. As I look around, I don't see these people in the audience. We look more like this, I hope. And so I think we ought to focus our time and energy in this area and moving things into the perioperative sort of arena. And that would be neoadjuvant or adjuvant or immediate perioperative therapy. There are two other ways we could do stuff. And one of these is a window of opportunity trial. And this sort of works by giving a novel agent, a non-FDA approved, something we don't really understand or anything like that. And we give this for a period of time once we get FDA approval, whatever. And then you operate on the person and you take a biopsy beforehand, and then you get the tumor specimen after, and you can do a lot of comparisons and see what differences are, what you are actually doing. I've alluded to some of this, but the tumor microenvironments are highly plastic, they're dynamic, it's complicated. But this gives us at least something. So drug mechanisms, this is a favorite topic of mine, but, we really don't know how things work a lot of the times. You get these nice cartoons you can look at online, but the truth is we don't know. But these window of opportunities trials gives us a single time point. The truth is it's way more complicated. If you could play that video. We do this in an ex vivo setting, so I can avoid the FDA. But what we see is a lot of things that you couldn't otherwise explain. In this video, the lymphocytes are marked with a CD45, which is red. The tumor cells are green. You can see this lymphocyte walk right past several tumor cells. It seems seemingly unbothered to find one it likes and kills it. There are other tumor cells in this video that just seem to be not bothered at all, not just kind of hanging out. This is what we see a lot of the time. When we see effective immuno-oncology agents, it appears clustered. Explaining this and trying to move past it mechanistically are difficult, I'll say. I think the other way forward for us as surgeons is with regional therapy. Dr. Jarnigan, I won't go through regional therapy too much, but he just talked about hepatic artery infusion pump therapy. A lot of us in the room do this. But combination with immuno-oncology agents is certainly a possibility. We would love to get something else in that hepatic artery infusion pump besides fluoxuridine. Okay, for the next few minutes here, what I want to show you is things that I've tried at the NCI over the last 5 or 6 years to sort of engage the immune system in cholangiocarcinoma. So this was a trial that is called perioperative MVT-5873. This is a monoclonal antibody against CA19-9. And we gave this to people right before surgery and then 4 doses right after. The reason I did this was for this reason. So in this video, this is sort of how I look at the metastatic cascade in tumor biology, especially for these bad actor cancers like cholangiocarcinoma. Pancreas cancer would be another example. These tumors probably shed cells very early on, probably everywhere, in the liver predominantly, but probably all over. And we can cut stuff out, but we can't stop that from growing. And that's the real problem. So I would give this antibody 3 days before surgery. I'd operate on the patient. The patient would undergo, a Whipple operation or whatever they needed to clear the primary cancer. And then they would continue to get 4 other doses of the therapy. The concept being we would have the antibody bound to the disseminated tumor cells, and then we would activate the immune cells to recognize this, probably mostly natural killer cells, and they would then clear the micrometastases, and we would prolong recurrence-free and hopefully overall survival. This is an example of a patient we put on the study. It's a 69-year-old lady, straightforward Whipple. You could see after the first dose of the study drug, CA19-9 levels drops, working. I didn't give her water. She got a surgery. Her CA19-9 level stayed low. She's actually doing quite well. But what I saw in this trial, and this happened to her, we saw abnormalities in liver function tests. And for her alkaline phosphatase went to 2200. The FDA kind of frowned on me for continuing the treatment. Several other people's bilirubin went high, and I ultimately decided to close the trial. I share this with you because I like the trial design. I think it's an important trial design. Medical oncologists are not going to do this. We have the opportunity to do this. I don't have a better drug yet, but I think it's an important trial design. All right, the last thing I'll show you in the interest of time, so I don't block Ryan out here, is this new trial that we have with M9241 in combination with hepatic artery infusion pump therapy. There's 2 cohorts. I'm not going to talk about the colorectal cohort. I almost always have multiple cohorts in studies because I think it makes sense to do things that way. So forget that group. The cholangiocarcinoma group, this is a schema of the trial we have ongoing. I have our first cholangio patient, I think Tuesday or Wednesday or something like that. And so what M9241 is it's an antibody that binds to histone. So anytime you induce cell death, cell damage, some tumors, especially colorectal, have a lot of endogenous necrosis. It will bind to this area and deliver an immunocytokine. And this will be delivered in high doses if you can get enough antibody there. IL-12, if you know the story about IL-12, it's a pro-inflammatory cytokine. It does stuff, but it is toxic if you give it systemic. So this is a way to deliver it to that quintessential, you talked about the cold tumor. This is a way to get it hot. And so IL-2 induces the production of other cytokines like interferon gamma, of course. It induces proliferation of NK cells and T cells, leads to the differentiation of helper T cells into the Th1 subtype and activates effector T cells. So we're sort of excited about this. The study design is going to be as follows. So obviously patients will get tissue at the time of the pump placement. They will then get FUDR and nothing else in the pump for the next 2 weeks. No systemic chemotherapy is given during this first cycle. On day 15, which is the time the pump is FUDR is changed out for heparinase saline, they get subcutaneous administration of the study drug M9241, the IL-12. And what we found is that the subcutaneous administration, honestly, is just as good as IV administration. You just don't get to charge for the infusion center. But so that's how we do this. And then on the second cycle, they start with systemic options, which would be GemOx for the cholangio group. And so we're excited about this trial, and we're excited about the immune analyses built into the trial, so we can begin to understand if we are in fact changing that immune microenvironment. Are we getting a hot microenvironment where we started off with a cold microenvironment? So these are strategies. You can probably guess the next thing I'm going to try, if this looks like it works and it's safe, is we would add durvalumab to see if we can augment those responses with the checkpoint inhibitors. I don't know if it'll be durvalumab, if it'll be some combination of durvalumab. I think we're in a very exciting time for cholangiocarcinoma. We have a small signal that checkpoint inhibition does work. I would not have guessed that it would work for this, but it appears to. And so I think there's a lot that's going to happen in the next few years. Perfect time, and I will stop.
Go ahead, move on to the next talk. We're running a little behind.
The next speaker is Professor Rebecca White. She's the University of California, San Diego. The topic is ablation as immunotherapy.
All right, thank you for the invitation. So for disclosures, I have no financial conflicts, but I do have NIH funding to study irreversible electroporation, or IRE, in my lab, and I have received some funding from angiodynamics in the past. So I guess you could say I do have a little bit of an academic conflict of interest, but I'm not a zealot. I know that electricity is only one of the 5 elements of nature, not exactly, but it is one of several physical methods of tumor ablation that are currently in use for HPB tumors. Now, I know you may not think of irradiation as a form of ablation, but it is. And in fact, it is the form of ablation where we first used the term abscopal effect. And it's going to be all about abscopal effects here. Abscopal is Latin for away from the target. And the abscopal effect is basically it's the very successful result of in situ vaccination. And we all know that vaccines can have variable success rates. And the mechanism of in situ vaccination is that ablation kills a tumor in the setting of inflammation, releasing neoantigens. There need to be antigen presenting cells around to receive those neoantigens and therefore stimulate an adaptive immune response by activating effector CD8 cells. So you have three basic ingredients. You need neoantigens, antigen-presenting cells, and effector T cells. So I'm not going to speak further of irradiation in the interest of time. I'm going to speak very sort of big picture about these different, more direct and immediate forms of ablation and their roles in liver and pancreas primary tumors. And because there are so many studies, I felt the need to construct an evidence pyramid. So spoiler alert, no randomized trials. In fact, there are really no measurable rates of abscopal effects in humans with HPB tumors with ablation alone. So in the absence of that, how can we measure these adaptive immune effects? So starting at a low level, you can look at local immune effects in preclinical models. So that gets you your entry-level evidence. It's then relatively easy to measure systemic adaptive immune effects in preclinical models because you can do things in mice that you can't do in humans, like re-challenge them with tumor cells or transfer their immune cells to other mice. So that gets you a slightly higher level of evidence. It is possible to measure abscopal effects in preclinical models using either artificial or spontaneous metastasis models. A very popular one is to use bilateral flank tumors. So that gets you a medium level of evidence. But then this is where it gets more difficult. It is harder to show these systemic adaptive immune effects in humans. It is possible to look at bulk immune cell populations, such as T cell subclasses, but it's much more, if you know what antigens you're looking for, neoantigen specific responses are much more sensitive and quantitative in terms of measuring these responses. And so I think that's the level of evidence we're aiming for right now. Now, I've just cherry picked a few of what I think are the best studies that exemplify this. So in HCC, ablation is standard of care. So there are lots of humans who have gotten thermal ablation. And we have some idea of what the relevant neoantigens are. So in this study from Germany, they looked at 7 rationally selected neoantigens. They measured, they took peripheral blood pre and post ablation, and they showed that about 25% had neoantigen specific T cell responses after ablation. And better yet, survival was improved in those 5 patients. So I think that's actually a pretty high level of evidence that something is going on at a systemic level. And there have been similar studies in HCC with cryoablation and IRE. Now, HIFU or high intensity focused ultrasound, that's a very general term, whereas histotripsy is a more specific form of HIFU, where the high intensity ultrasound waves result in cavitation and therefore kill the cells. And I specifically wanted to single this out because it almost sounds too good to be true, and it is work being done by a fellow surgeon. So Cliff Cho and his group at Michigan have looked at histotripsy in a murine HCC model and shown that it can induce abscopal effects in this somewhat artificial model, and shown that these cells did die by an immunogenic cell death. And there are clinical trials ongoing. So we don't have that higher level of evidence, but we do have some medium level evidence. Now, pancreas cancer is not liver cancer for many reasons, although they do share a similar moderate tumor mutational burden. But beyond that, liver tumors tend to be hotter than pancreas tumors. They have more CD8 T cells at baseline. But I think the real difference lies in their anatomy. Obviously, it's a lot harder to get ablation probes into pancreatic tumors than into the liver. Also, a much higher proportion of pancreas tumors have vascular involvement, which introduces the heat sink effect. This is why irreversible electroporation, or IRE, I think, has become the front runner in ablation for the pancreas. IRE, as I think many people are now familiar, it's a non-thermal form of ablation. There's no heat sink effect, and in theory does not damage acellular cartilaginous structures such as blood vessels. So I've done a lot of work in this area, so has Rob Martin's group, but the best evidence I think that IRE is generating systemic immune effects in humans actually comes from the Netherlands, where they do a lot of percutaneous IRE for pancreas cancer. And they looked at another rationally selected neoantigen, the Wilms tumor 1 antigen, which is not really a dominant or strong neoantigen. And yet they were able to show in blood pre and post IRE that a significant minority of patients generated reactivity to Wilms tumor 1 or had boosting, and that this also correlated with survival. So I think that's pretty strong evidence, the best we've got in IRE, with some preclinical studies showing evidence for thermal ablation, cryoablation, and histotrypsy in pancreas cancer. So IREs are front runner, but you only need to look at our clinical experience with IRE to know that the real problem is distant recurrence, because we can get good local control with ablation, but just like they do after surgical resection, most patients are going to have distant recurrence. So we have to do better, and there are numerous opportunities to try to improve immune responses to ablation. I have just picked out some of the ones that are being actively studied. And now I'm going to shamelessly talk about the work going on in my own lab right now, which is focused on CD40, which is a receptor that is expressed on antigen-presenting cells and serves as a bridge between the innate and adaptive immune systems. And CD40 agonists are being studied currently in advanced pancreatic cancer. So, based on our prior work, we hypothesized that the combination of IRE with local delivery of an agonistic CD40 antibody would be synergistic. And we used an orthotopic mouse model. It's a KPC organoid cell line that's very aggressive and metastasizes to the liver within a few weeks when you implant it into the tail of the pancreas. And we basically combined IRE with a single injection of CD40 antibody at the time of IRE. And what we showed is that CD40 alone doesn't do much. IRE does have some effects on local tumor growth, as you would expect, but the combination was synergistic in terms of local tumor control, including several complete responses, and this resulted in improved survival in those mice. And this is good, but somewhat expected. But what we were really happy about is that it also significantly decreased metastatic disease burden in the liver. And remember, this is an all local therapy. Nothing was delivered systemically. So with this all local therapy, we saw decreases in metastatic burden when measured in a variety of ways. And you might say, well, is that just because you've controlled the primary better? You could say that, but we did also see a significant increase in CD8 T cell infiltration into those liver metastases. So we think is compelling evidence that there's something going on systemically here. Now, the next step is, are these T cells actually neoantigen specific? So I've collaborated with an immunologist at the La Jolla Institute. They have an unbiased mutanome profiling method that allows us to identify candidate neoantigens from sequencing. We identified neoantigens in our mouse model. We made peptides representing those candidate neoantigens, and we tested them against T cells from our treated mice. And we find that IRE does increase the number of peptide neoantigens that are recognized by T cells, and that the combination further increased this, which we think represents epitope spreading. So I'm very happy to say that I just last week got a 5th percentile score on an RO1 that would support a clinical trial to use this exact same strategy in humans. So the idea is that we will deliver a single intraoperative dose of a CD40 agonistic antibody at the time of IRE in humans. We will profile their neoantigens and test their PBMCs pre and post IRE to see if we can see these same neoantigen specific responses. So that is going to happen. So in summary, ablation is really the ultimate form of personalized immunotherapy. And I think there's still a lot of unanswered questions, which, since we're well over time, I would be happy to discuss in the break. Thank you.
We're over time, but I really hope you stay for our last talk. Is Dr. Ryan Fields. He's Chief of Surgical Oncology at Washington University in St. Louis. We're talking about ctDNA applications and evidence.
Yeah, I thought we were doing pretty well with time, actually, especially up against the break. But I'm going to make this is very much going to be like ctDNA 101. And if you want 201, 301, 401, focus on the lower right-hand corner and the references, because I found there's some really good recent review articles and really nice summaries of the field. But let's kind of make this a bit of an overview. Here are my disclosures. So what is ctDNA? Let's sort of set the stage, or really what is cell-free DNA? So this can come through a variety of mechanisms: apoptosis, phagocytosis, necrosis, secretion. And this is important because everybody thinks of CT or cell-free DNA as looking at the tumor DNA, but there are cells from the tumor microenvironment shed into the blood, and that signal can be picked up. And I'll talk about that at the end, how you can almost do a quote, a biopsy of the tumor microenvironment in the blood using some of these technologies. And there's a lot of alterations you can pick up in cell-free DNA. It can be epigenetic, it can be apoptotic bodies, it can be translocations, really any genomic change. And so why is this important? What's all the fuss about here? Well, you could think of a lot of different applications. And again, this is a great review article. So could you use this as a screening test in high risk or in the general population to pick up cancer, say before it was evident clinically? And so that's a big area of work. Then once it's diagnosed, can you use cell-free DNA in lieu of or in addition to a tumor biopsy and use it to guide initial treatment based on mutational analysis? Then when somebody's treated with definitive therapy, whether it's surgery or anything else, they become NED. Can you then use it to monitor response, or MRD, minimal residual disease? That's probably where the best evidence is, and I'll talk about some of the data there. And then when patients recur, and as it was alluded to, a lot of these tumors are very heterogeneous. Can you look at different clones that are growing out? What are the resistant ones? Can that help guide therapy? So a lot of applications. This is why I think it's important compared to what we do in standard ways. This is a figure from a paper that we published, and under the red bar at the top are 14 different biopsies from a primary colorectal cancer. And if you look at the very bottom where it says KRAS, only in 3 of those biopsies did we actually pick up a KRAS mutation. So standard biopsies may miss things that you could otherwise find. Of course, we don't usually do 14 biopsies on the same patient. So can the blood be a way to monitor these clones and pick out these resistant tumors that may, again, have important treatment decisions? So what are the different testing platforms? And here's again where I want to give kind of a survey. I think everybody in the room kind of understands and knows what cell-free or circulating tumor DNA is, but there's a lot of different ways that you can measure it. This is, I don't expect to really go through and read this right now, but these are, again, from a good review article, some of the different platforms that exist and what the differences are. You can, again, look at single mutations or whole genomes. You can look at allele-specific techniques by PCR, where we're just looking for one mutation, and various enrichment techniques to really increase the sensitivity. That requires a prior knowledge of either mutations or defined mutations of cancer hotspots, meaning it's an informed assay. You kind of know what you're looking for. If you want to look at a larger number of loci, if you want to, you can use other techniques that, again, can increase the sensitivity. And if you think about kind of what's current out there, off the shelf type things, usually we can get things that are about 1% or higher within the peripheral blood. So they're not all that sensitive in that regard. There's ways to reduce background error. There's ways to do things like barcoding and run multiple different replicates, and we can get that sensitivity using those techniques down to about 0.1%. So to Ajay's analogy, this still isn't the 1 out of 100,000 that we really want to be able to pick out to have it that sensitive. Limits of detection are going to vary on a number of things, including disease status, prior characterization of mutations that you know about, prior knowledge of the mutation profile, again, allows you to develop a targeted panel that can look deeper. This slide kind of goes through the concept of a tumor-informed versus an uninformed approach. So off-the-shelf panels will cover recurrently mutated genes in cancer types of interest, these off-the-shelf panels, so they'll look at things that are known mutations. The same panel is then applied to tumor tissue and plasma of every patient. And personalization is achieved by considering only the positions mutated in the matched tumor. Personalized panels then would cover patient-specific mutations, so neoantigens, things that are unique to that one person, that one patient's tumor. And that approach, personalization, is achieved by every patient has a unique panel. You could imagine that's much more costly and labor-intensive to do it that way, but you, to some degree, can get a lot more information on clonal evolution and clonal selection. This, I think, is a great slide. And again, this article in Cancer Discovery really kind of puts a number of good figures to really understand the limits of detection. So at the top are a limit of detection with 95% confidence for various assays if you were to adjust various things. So increasing the number of mutations that you track, the sequencing depth at mutant positions, or the input that you analyze, the amount of plasma, the amount of DNA, can increase the probability of detection. So technical background from sources as well, like polymerase errors, oxidative damage, things like that can lower than the limit of detection and distinguish artifacts from two tumor variants. But if you look at, say, the far right curve, you can see we're getting the limit of detection down to 0.001, 0.0001. So very sensitive now, where you should be able to pick up very, very small burden of cancer well before you would see it on an imaging study for sure. I do want to describe the source of the idea of false positive ctDNA testing and the concept of clonal hematopoiesis. This is the most important source of error. So even if ctDNA molecules are recovered, their subsequent detection relies on quantification and bioinformatics and biological background secondary to somatic mutations that are seen in cell-free DNA, but not from the tumor cells, is a real concern. And this comes from age-related clonal hematopoiesis. So these are mutations that occur in PBMCs in the normal leukocyte populations. As you can see from the graphs here, this increases over time in terms with age, and the prevalence really will be found in almost everyone the harder you look. And as you get over the age of 60, it increases quite a bit. This is the dominant source of false positive mutations. And there's ways to correct for that by having that leukocyte population and knowing that background sequencing, kind of like you compare a tumor biopsy to a normal biopsy in standard genome sequencing. In genotype naive analysis, and we're looking at things like minimal residual disease, that sample is going to be interrogated at all genomic positions, leading to reduced sensitivity because you're basically testing multiple hypotheses at the same time. If you have a tumor genotype informed assay, however, variants are identified from that tumor tissue, meaning from that patient, or pretreatment plasma samples, and then you have a real high tumor allele fraction that you're looking at. So only patient-specific variants would be interrogated and are monitored in an MRD setting. So if you have a tumor-informed assay and in MRD, you can make it that much more sensitive. And again, in both cases, no matter what you're doing, if you can genotype the DNA from leukocytes in the peripheral blood, you can drop that biological false positive signal from age-related clonal hematopoiesis. So if you think about this then, and how can we figure out what's our limit of detection? If you compare the limit of detection of a tumor genotype naive or a tumor genotype informed cell-free DNA analysis, then if we sort of make an assumption that you're going to sequence at 5,000x coverage, which would be kind of a standard test that would be out there commercially available for a patient that, let's say, whose tumor had 6 mutations, and you were going to look for an allele fraction of 0.01%. If you were doing a genotype naive analysis, which is shown on the left, the limit of detection would be about 0.2%. You wouldn't see any of the mutations detected above background, despite the fact that you have mutations with allele fractions of 0.02, which is 1 in 5,000, 0.04, 2 out of 5,000 in this hypothetical scenario. In contrast, shown on the right is if you had the same sample in a genotype informed assay, using the same 5,000 depth coverage or 5,000x coverage, you'd have a limit of detection at a 95% confidence interval of 0.01%. So you would, your MRD test in this case would have a 95% chance of picking up one of the mutations. So it's that tumor-informed side that really allows you to drop the sensitivity of these assays significantly. So this is a summary, and again, I'm specifically haven't mentioned any brand names, anything like that. This lists a couple of the ones that are out there as, again, a summary of some of the tumor genotype requirements and limits of detection of these various platforms, and approximate for ones that are, again, that are commercially available. Because no data has really compared any of these methods, we're not seeing head-to-head things like that. The approximate limits of detection that are listed here is really estimated from a large number of published studies. But you can see we're getting down to the level of 0.01, 0.0001% with some of these informed assays, looking at various ways. So it's becoming a very powerful tool. I want to give just go through one study that I think really shows the power of this and where the future is, both for us as surgeons thinking about these as correlative studies for trials that we run and where it really works. And this is This is the Galaxy study that's part of this very large Circulate Japan project that prospectively monitors ctDNA from patients with stage 2 to 4 colorectal cancer. And this is specifically the ctDNA publication that just came out in Nature Medicine literally a few weeks ago. And it looked at positivity with patient outcomes and implications for adjuvant therapy. And the numbers that are hard to project there, but this is over 5,000 patients. This is a large study that includes a lot of resected stage 4 patients. And this is the power of it here. So this is disease-free survival stratified by one cell-free DNA test 4 weeks after surgical resection of stage 2 to 4 disease. And it's 108 of the 187 patients who were positive. Again, one test 4 weeks later, 61% had recurrence. In the patients that were cell-free DNA negative, 10% recurrence rate. And you can see this goes out to several years and the curves flatten out pretty well. And this held across stages. If you looked at this in a multivariate model, the hazard ratio was 10.8. It was the strongest predictor of recurrence. The other important thing is how does it correlate with a response to adjuvant therapy in post-surgical patients? So again, one ctDNA test that was positive benefited from adjuvant chemotherapy across stages. Conversely, of patients that were high risk stage 2, 3, 4 patients, but had a negative cell-free DNA test, there was no benefit to adjuvant chemotherapy. So again, this is disease-free survival. This is very young and somewhat immature data, but I think this is where we're going to see the power of this in the MRD setting. I wish I had the same study to show you for cholangiocarcinoma. I'm going to skip through these slides pretty quickly because the references are there, but really in cholangio and biliary tract cancers, we're really at the point where we've shown you can pick up these mutations in the blood and not a whole lot beyond that. What's next? Well, I alluded to the fact that we often will consider this cell-free DNA. There's a lot of different places that this technology is being looked at, including even things like the tears in various cancer types of the eye, in cerebrospinal fluid, really anywhere that you can detect it. Pancreatic cysts is a big one. I think we're going to hear about that a bit in the next session. And I alluded to a couple things as we increase the limit of detection. That's going to really allow these tests to be more sensitive and specific. Can we use them in a population for screening in high-risk patients, high-risk populations, say for pancreas cancer, where you can really look at one mutation like KRAS in a large cohort of patients. And then there's this real ability to use cell-free DNA to not just look at circulating tumor DNA, but almost do what we would call a liquid TME or a biopsy that really gets a sense of what the tumor microenvironment looks at to help better select patients for immunotherapy approaches, things like that. And I think that's the focus of the R01 that we have looking in this space, and a lot of people really looking at trying to extend the ability to look at non-tumor DNA that's associated with the microenvironment. And what that may allow us to do is take patients that are circulating tumor cell-free DNA positive versus negative and best select them for escalation or de-escalation of therapies, which, as we all know, have toxicities and ramifications. So we'd much rather be able to get the right patient on the right therapy at the right time with a non-invasive assay like this. These are a couple of the papers that I've referenced, along with a few others that I think are really good reviews or really good sources of information for cell-free DNA 201, 301, and 401, and more information. So thank you, and it's been a great session.
Thank you. Thanks for staying, everyone. A lot of novel current and future therapies as adjuncts to our surgical treatment of HPB malignancy. And aren't you all glad you came here instead of the competitive video session? Have a great afternoon.